Hello, and thank you for viewing the 2025-2026 Medicare Update webinar. My name is Bev Bromfield, Patient Education Programs Manager here at NPF. Before we start, a few words about what the National Psoriasis Foundation does. At the heart of all we do is our mission to drive efforts to cure psoriatic disease and improve the lives of those affected. We accomplish our mission by funding research with over $37 million awarded in grants and fellowships, along with collaborative and transformational research initiatives. New grant and fellowship recipients were awarded in July. The NPF also offers education for those living with psoriatic disease and encourages all to become involved with our mission. Learn more about our research, education, advocacy, and how you can become involved by viewing the links listed on this slide. Now, I'd like to take a moment to acknowledge and thank our presenting sponsor, Novartis, for their support of today's webinar. Thank you. It's my sincere pleasure to introduce you to our moderator for today's webinar, Jason Harris, Vice President of Government Relations and Advocacy here at NPF. Jason joined NPF in 2022 with over a decade of experience leading efforts to address health policy that benefit those with chronic health conditions, from those with psoriasis and previously with the Lupus Foundation of America, the National Health Council, and the ALS Association. Thank you, Jason, for being with us today.
Hello, everyone, and thank you for joining me today for this Medicare update. Today, we have Speaker Kevin Lawrence, Director of Medicare Sales with Professional Group Plans, or PGP benefits. Kevin has dedicated the last 19 years helping seniors with their healthcare needs. During this time, he has become a top producer in Medicare supplement plans, Part D plans, and Medicare Advantage plans, being very knowledgeable of the Medicare market and the maze it represents for his clients. He takes pride in helping his clients learn and be confident in their plan choices. Kevin's well known in the brokerage community as an expert on eliminating the confusion surrounding Medicare. It is my pleasure to welcome Kevin Lawrence as our speaker for this webinar addressing the 2025 and 2026 changes to Medicare. Welcome, Kevin. Thank you for being here today. I think just from your bio, you'll connect well with our community as they've had to deal with many problems. So, show's yours.
All right. Thank you very much for the introduction, Jason. All right, so we're going to be talking about a lot of the basics of Medicare. Just as an introduction, we'll go over some things that like what Medicare covers, what it doesn't cover. We'll talk about the different products that are available in Medicare, and we'll talk about enrollment periods and things like that. So at the end, we'll also do some Q&A, so try to answer as many of your questions as we can possibly in the time frame that we have. So this is a little bit outdated. There's probably closer to 67 million people that are on Medicare right now, and typically in order to qualify for Medicare, you have to be 65 or older, or there are certain scenarios where you're automatically enrolled in Medicare. So one of them is if you have kidney failure. You could be covered under an employer plan, but still be in a situation where you have a very significant out-of-pocket cost. So the idea behind adding Medicare to the mix is to help reduce your out-of-pocket costs. This is ALS is also in that situation as well. So if you are, God forbid, diagnosed with ALS, they'll automatically enroll you. And then also, if you start to collect Social Security disability income, regardless of age, after 2 years, they will automatically enroll you in Medicare A and B. All right, what's automatic? So there are people that are under the impression that they're automatically enrolled in Medicare A and B, and that's not necessarily the case. One of the big reasons that people are not enrolled in Medicare A automatically is because many people are on high deductible health plans where they contribute to HSA accounts. And you cannot contribute to an HSA if you're automatically enrolled in Medicare Part A. So the only time that you're automatically enrolled is what I mentioned earlier, at 2 years after being collecting Social Security disability income, or if you decide to start collecting Social Security income. Let's say you're 62 years old and you start that income stream. When you turn 65, you'll get a Medicare with card in the mail with Part A and Part B of Medicare on it. You can opt out of Part B if you have coverage elsewhere at that point in time now. Okay, so Part A of Medicare covers inpatient hospital stays, and you see the items here that are covered under Part A of Medicare. So from a cost standpoint, if you have no other insurance in place, I just want to give you an idea of what Medicare Part A covers. So Medicare Part A would cover just about the entirety of the hospital bill with the exception of a deductible of about $1,700. After a period of time, then there would be a copay after roughly 60 days where you would have a copay on a per day basis, but it's not very often that people are in the hospital for a significant length of time like that. If you were in the hospital and then you transitioned to a skilled nursing facility because you're not well enough to go home, the way that works is Medicare, original Medicare, will cover the first 20 days at no cost. Starting on day 21 through day 100, there's a $209 copay for those 80 days. So that can get pretty expensive. One of the things that Medicare is designed to do is to help reduce or somewhat eliminate your out-of-pocket costs. So there are things called special enrollment periods where you're allowed to switch your plans. If you're in the hospital and you go to the skilled nursing facility, you automatically have the ability to change your plan. So if somebody did that today is October 17th, they could effectively be in a different plan on November 1st. Now, I do caution that in most states, people are required to answer medical questions on the applications for a supplemental plan because the proper coverage for skilled nursing would be a supplement plan as opposed to an advantage plan. So it doesn't always work, but in New York, where I live, I can move people to a skilled nursing facility and they will be able to get that supplement plan in place that would pick up the 80-day copays. Home health care is also covered under Medicare, but it's really just a short period of time where they'll help you, transition back into the home. It's not something where they will send in a nurse 8 hours a day to help you with the activities of daily living. And any medications that you're given in the hospital will also be covered under that deductible that I mentioned earlier. All right, so in order to qualify for Medicare Part A, you have to have worked for at least 40 quarters and paid into the system. Now, there are situations where there may be a non-working spouse that does not qualify for the 40 quarters. In a case like that, what they can do is they can access the working spouse's history in order to pay or in order to avoid having to pay for Part A of Medicare as well. So it's pretty rare that people have to pay Medicare Part A premiums. Okay, so Part B of Medicare covers all the things you see here: doctors, surgeries, MRIs, lab work, emergency rooms, preventative care. The way Medicare Part B works is there is a premium that's associated with that, and we'll go to that on a future slide. But in terms of the coverage that Medicare Part B offers, what happens is you'd be responsible for a Part B deductible every calendar year if you have no other insurance in place. Calendar year deductible for this year is $257. It looks like it's going to somewhere around $280 next year. That hasn't been formally announced as of yet. But after you meet that $257 deductible for this year, then Medicare will pay 80% of any claim and you would be on the hook for 20% of the claim. Now, again, that could be 20% of an office visit or 20% of a surgeon's bill. So it's always a good idea to have some level of coverage and to cap your exposure on those types of out-of-pocket costs. Okay, so the only thing that's really relevant here is how the premium is paid. If you're collecting Social Security income, they'll deduct that premium out of your check each month. If you're not collecting Social Security income, then they'll bill you on a quarterly basis. Once you get your first quarterly bill, you do have the ability to set it up where they can do an auto payment on a monthly basis out of a credit card, or I still believe they offer a bank draft as well. All right, so here are the premium charts for 2025. When they look at your 2025 income or premiums, they'll be looking at your 2023 tax returns. The reason they're always 2 years behind is because next month in November, everybody's going to get their notification for their 2026 premiums. Obviously, you haven't filed your 2025 tax returns because the year's not even over. So they go back 2 years. Now, These premiums are not locked in stone because if, let's just say for argument's sake, you're going to retire in January of next year, they'll be looking at your 2024 tax returns. In that case, you can say, listen, in 2024, yes, I was in one of these higher income tiers, but now that I'm retired, my income is going to drop me into a lower tier. Medicare allows you to appeal that the premium amount so that you can get your premiums reduced right away, so you don't have to wait 2 years for the reduction in your income to be reflective of your Part B premiums. In cases of retirement, they pretty much rubber stamp those types of deals. There are situations if you had a spike in your capital gains by, big investments, or if you sold a piece of property or something like that, you may have to suck it up for a year, but in the following year, then your premiums would go back down based on 2 years prior. So you'll see that there's two ways that they look at this, either as an individual or a married couple. So it depends on how you file your income taxes. So if you're a single and you made less than $106,000, this year's premium is $185. That would also be for a couple that are making under $212,000. And you see, as you go up the income scale, you see an increase not only in the Part B premiums, but the Part D premiums. So if you go up to the second level, the 106 to 133 and the 212 to 266, you get an income adjustment. It's called an income-related monthly adjustment amount, which is a very fancy way to say tax. So now your premium goes up to $259 a month per person, but now you also see that they hit you with a surcharge for the prescription drug component as well. So what happens is the idea is that they're going after higher income earners to help keep the program solvent. And as you can see, if you make a significant amount of money, the premiums can be, over $700 a month when you combine your Part B premiums and your Part D premiums. Now, I get this question a lot. People say to me, well, I already bought a drug plan from, XYZ insurance company. Why am I paying this additional fee? And that's why I essentially call this a tax, because it's essentially your entry fee to get into Medicare. So if you are above the base level, you're going to pay those premiums in addition to any insurances that you pay, whether it's supplement plan, drug plan, or whatever. So this is a fixed cost, and then determining what plan makes the most sense for you is something that will vary based on your healthcare needs and your budget. All right, once you have Medicare A and B in place, then you have the choices of determining whether or not your proper insurance would be to go with an original Medicare scenario, where you get original Medicare A and B, you pick up a Medicare supplement or a Medigap plan. Those terms are synonymous. And in order to make sure you have the coverage for medications, you also pick up a Part D plan. For people that want more comprehensive medical coverage, I usually recommend a Medicare supplement plan, only because you have a wider range of providers that you have access to. So any doctor, any facility in the country, you have access to those doctors. The supplement plans themselves have various different levels of coverage. And the idea is essentially that if you pay less in premium, you'll pay more out-of-pocket costs on the back end. So whenever a client comes to me and they want to go with a Medicare supplement plan, I usually try to get a handle on what their healthcare needs are. And in many states, as I mentioned earlier, you need to answer medical questions if you want to upgrade your coverage in the future. So in a lot of the other states in the country, outside of New York, Connecticut, and Massachusetts, there's not a big difference between the best plan and the second level of coverage. So rather than jeopardizing your coverage, 5-10 years down the road, I usually recommend that people spend the extra $15 or $20 to get the best coverage. This way, as long as they pay their premiums, they'll always have it and they can ride it into the sunset. One of the other things that is a very good component on the supplement plans is that if you're traveling outside the United States and you have an emergency, Medicare will not pay anything towards your medical services. But the supplemental plans, many of them have foreign travel benefits, which essentially would make it work this way. You pay the bill You come back to the States and you submit the claim to the insurance company. The insurance company will charge you a $250 deductible. Then they'll pick up 80% of the claim. After that, you would be on the hook for 20% of that. That benefit is capped at $50,000 over your lifetime. So it doesn't sound like it's a significant benefit from that aspect, but I've seen the bills that come in from outside the States, and they're not anything close to what we see here in the United States. The other option is a Medicare Advantage plan. So those are the plans that you see the commercials for on TV. You know, if you call the Medicare hotline, you make sure you get all the benefits that Medicare offers and things like that. So the way the Medicare Advantage plans work is they're actually subsidized by the government. So in many cases, you don't necessarily have to pay a premium for the plan itself. You still have to pay the premiums that we talked about on the earlier slide, but you don't necessarily have to pay a premium for the plan itself. The reason is because the insurance company makes more money off the check that the government sends in, so they don't really want to charge you a premium. They want to entice you to take these plans. So they work well for people that are in good health and don't go to the doctors very often, because the way it works is you only pay for services as they're provided to you. So if you go to the doctors, a handful of times over the course of the year, these can be very cost effective. Now, there are some restrictions as far as networks go. So anybody that looks to go to a Medicare Advantage plan, when we talk to our clients about that, we ask them to provide us with a list of the medications that they take, and also their providers, what doctors, what hospitals, what facilities for things like MRIs or mammograms. And we make sure that any plan that they choose will cover those providers. And if those providers are not covered, we'll at least let them know that, we would have to go with a PPO plan if they want to continue to see that one particular provider in order for them to be able to still have coverage there. Okay, I think I've covered a pretty good chunk of these things. One of the things that I didn't mention on the Advantage plans is that they do cover some of these services. So they might provide you with a little bit of dental benefits, some hearing aids, some routine eye care, and things like that. So those options become available to you on the Advantage plans, but not on the supplement plans. All right. Well, I think I covered everything here with the exception of the guaranteed issue at time of eligibility. So I talked earlier about how if you want to upgrade from one plan to another, you have to pass medical underwriting. When you are first going into Medicare, either at age 65 or when you're coming off of an employer plan, they cannot ask you medical questions at that point in time. So you're able to get in and pick and choose from whatever plan that you want at that point in time. So everybody gets at least one chance to get in without the medical underwriting. Okay, in terms of the Medicare Advantage plans, they have to cover everything that original Medicare covers. The only difference is the Advantage plans will have different costs than a Medicare supplement plan. And one of the things at the bottom is that you must reside in the service area of a plan. So if you're in a particular county, if you move over to the very next county, it could literally be a couple of blocks away. But if you're in a new county, Medicare requires that you move from the plan that's available in your current county to the new plan. It doesn't mean that you can't access providers that you're accustomed to. It just means that you have to get a plan that's situated in the new county that you live in. And certainly, if you move from one state to another, you have to change your Medicare Advantage plan. The only thing that's really important here is, as I mentioned earlier, you have PPO options where if you needed to go outside the network, you have the ability to go to see any doctor that accepts Medicare. Costs when you go outside the network are higher than if you're using a network provider. So that's one of the things that you have to take into consideration. The one other one that we deal with a lot are the HMOs. So if you go to that type of an option, then you have to stay within the network outside of emergency scenarios in order to make sure that you have the proper coverage or that you're going to have your claims paid, excuse me. All right, so this is something that I know everybody is going to be concerned about when it comes to the medication costs is without having to explain all the little details in this, it's really just easier to let you know that your drug costs are capped on medications this year and going forward. It's part of the Inflation Reduction Act. And what happens is, as long as your medications are covered, that's the key component. As long as the medications are covered on the drug plan that you're choosing, you're capped out at $2,000 worth of out-of-pocket costs for the year. So you could be on a medication that costs, $15,000 a year. The likelihood is that in that particular case, when you go to fill that medication in January, you're going to pay $2,000. In the old days, you would end up having to pay roughly 5% of that drug for the rest of the year in the catastrophic phase. But now, once you hit the $2,000, you're done. You don't pay anything else for the rest of the year. Now, there are two ways to pay that $2,000. You can either pay the $2,000 right up front in January and rip the Band-Aid off, or you can set up an account with the insurance company where they'll say, all right, we'll cover the $2,000 in January and we'll bill you the balance every month. So essentially around $167 a month. You'll get a bill from the insurance company each month for that to cover the $2,000 that they laid out. And again, this is it talks about, who's paying what here and everything else. The bottom line is that for my clients, they know that as long as their medications are covered, once they lay out $2,000, they're done until the following January. I have a handful of clients that are on some pretty expensive medications that are looking to go to Medicare for December of this year. And what I've told them is I've actually told them that it's less expensive to stay on their employer coverage for another month rather than having to lay out $2,000 in December and then start right over again in January and get hit with another $2,000. Timing of it can be key as well. All right, so the only thing that's really relevant here is that the network pharmacies, except under special conditions, most drug plans have pharmacy contracts with just about all of the major chains. Mom and pops, sometimes you have to check with them to see what the kind of plan that they or what plans they contract with. But the other thing is that outside of people that are going to want to hit that $2,000, I usually make sure that we get their pharmacy that they use, because if they're taking, let's say their drugs cost $1,000 a year, it might cost $1,000 at CVS, but it might cost $800 at Walgreens or something like that. So we always try to make sure that we're getting the best fit for the client and the most cost-effective plan for them. Okay, limited income subsidy. The limits on these are fairly low, but this is an extra help program for Part D that's actually run by the government. So anybody that signs up for supplements, drug plans, Medicare Advantage plans, they get a letter from the government to talk about this. Again, the income tier or the income caps on this are very low, so it doesn't always work. It's not quite Medicaid, but it's not readily available to a large percentage of people that are out there. But certainly, if your income is fairly low, it's always a good idea to fill out the form. The worst they can say is no. And if you qualify, they help eliminate a lot of your costs, whether it's premiums, co-pays, deductibles, all those types of things. So it is a good benefit. There are a handful of states still that have what are known as SPAPs, State Pharmaceutical Assistance Programs. We have a very rich one here in New York called EPIC. And I usually tell people if they qualify for it from an income standpoint to enroll in EPIC. One of the reasons that it's really good to have is because the fact that you qualify for it also gives you the ability to change your plan outside of the normal enrollment periods. So if I have somebody that's on a plan and they get a significant change in their diagnosis and now all of a sudden they need to upgrade their plan, we can get them by virtue of having the extra help through EPIC. I can get their plan changed the first of the following month. So it's been very helpful for my clients, not only on the reduction in cost of their drugs, but also having the ability to switch out of the plans mid-year if something serious changes in their healthcare needs. Okay, so the key thing here is that VA coverage is also considered credible. So if you retire and you don't want to pick up a drug plan, because you have the VA benefit that works. It's credible coverage, so you'll never get hit with any kind of a penalty or anything like that. But it's a very good benefit, and in some cases, the drug can be a lot less expensive through the VA. All right, so these are some key enrollment periods. First one is your initial enrollment period when you first become eligible for Medicare. So it's 7-month window, 3 months before your birthday, the month of, and 3 months after. So my initial enrollment period is actually opening in December because I'm going into Medicare as of March of next year. I want to make sure that my coverage for Medicare goes into effect on the birthday month. So what I'm doing is I'm going to proactively enroll, because if I wait to do it until the month of my birthday, then the coverage doesn't go into effect until the following month. And yes, I still have more time to enroll in Medicare A and B, but the longer you wait, the longer it takes for the coverage to go into effect. So the next election period is the annual election period, October 15th to December 7th. That's what we're going through right now. It's my busy time of the year. People can take a look at different options for their medication plans, for their drug plans on the supplements, as the Medicare Advantage plans as well. So you do your homework and you make the changes based on whatever changes you might have, maybe new medications, maybe new doctors if you're on a Medicare Advantage plan. And any change that you make during this period of time will go into effect January of the following year. So again, it's our busy time. Most of the people are looking at, changing their drug plans or making sure that their medications are covered based on what we talked about earlier. The special election periods, I've talked about a number of those. And the last one that you see here is the open enrollment period. So this is something that Medicare brought back. If you have a Medicare Advantage plan, anytime between January 1st and March 31st of 2026, in this case, you can go from one plan to another. So MAPD stands for Medicare Advantage Plan with drugs. If I go to my doctor in January and I find out that I didn't do my homework and my doctor is not covered, then I can absolutely change my plan. I can take an application for the plan that my doctor does cover. And if I make that choice in January, on February 1st, I'm in the new plan. You also have the ability to go from a Medicare Advantage plan to original Medicare, a supplement, and a Part D plan. Now, the only thing that happens in that situation is, depending on the state that you live in, there could be medical underwriting. So that is not a guarantee that they're going to give you that option, the insurance companies, but you would at least have the opportunity to pursue that particular change. All right, Part D penalties. If you don't have a drug plan in place that's considered credible and you sign up for a plan later on, you can get hit with a penalty. This month, all of the people that are on corporate plans, their company is required to send out a letter saying whether or not their drug plan is credible. Because if you're eligible for Medicare and you're working for a company that has that's where you have your medical coverage, if you find out that your drug plan is not credible, you can actually enroll in a plan that would coordinate with the benefits that you have through your company, but it would help protect you against the penalty that would come down in the future. So right now, the penalties are roughly $8 or $10 a month. Those penalties are going to go up because the calculation is the premiums on the drug plan, or it has to do with premiums on the drug plans in your area. The drug plan premiums are going up significantly this year. Again, they did last year as well, as part of the Inflation Reduction Act and the guarantees that these insurance companies have to provide. So I've seen some fairly large increases over the last few years, certainly much more than I've seen in the first 18 that I've been doing this. So that penalty can rise in the future, and that penalty is charged every month for the rest of your life. So it's always a good idea to make sure your drug coverage is credible. When my clients come to me and say, I'm not taking any medications, I would prefer not to take a plan, I always mention this slide. And I also mention to them that if they're prescribed a medication in the middle of the year outside the enrollment period, it's very difficult to get a drug plan in place in mid-year. That's just some contact information from Medicare. And that's my contact information. If anybody has any questions or if they want to have a conversation about their particular needs, they can always email me. That's the best way to get me. I'm on the phone pretty much all day during this time of year. I believe we're going to talk about some questions at this point in time, Jason, correct?
Yes, sir. Yes, sir. And Kevin, thank you for that great presentation. I took a few notes as you were going in terms of some of the highlights for me that I think are really critical, right? Timing is everything. Making sure that we all of us, whether you're helping someone to prepare for the transition or just for checking out what the coverage is for the next year, and really doing that homework to understand what might be covered, what might not be, how does that impact what we're looking to do. And my mom recently joined Medicare, and she was all about the supplemental plan. So I wanted to just throw that one in there too. Okay. And you mentioned, I want to start a little bit with some questions we got related to insurance coverage and sort of, I think Medicare Advantage a little bit as a theme. Can you talk us through, just kind of remind us one more time, you went through it, but if someone makes a mistake, if they go with Medicare Advantage and they can't get the supplemental plan, what does that process look like for them? Like, I think that's helpful just to continue.
Well, it depends. So like in some states, like New York, if somebody takes an Advantage plan, they want to move to a supplement plan, that's pretty easy. I'm always a little leery about selling the Advantage plans to people outside the, outside of the New York, Connecticut, Massachusetts areas, because those are the ones that are a little trickier to move. And I'll tell my clients, listen, okay, you might be in perfect health right now. You only go to the doctors twice a year, but what's your family history like? If your family history is not good, then maybe even going with the Advantage plan in the short term is not a good idea. So a lot of it really comes down to getting the proper advice right up front and understanding, the pros and cons of each. When I talk to a client, I give them the pros and cons of an Advantage plan and the pros and cons of a supplement plan. And then they have to make the decision based on what's best for their healthcare needs and their budget.
Thank you for that. I just think that point can't be reiterated enough in terms of if you're not quite sure, talk to an expert, try and get a better look at what it could look like. So I think one thing our community was, very excited about, and many of us worked on, trying to pass policies and legislation that brought that out-of-pocket cap in Medicare for Part D. With that, there were Medicare was also a part of the Inflation Reduction Act. Medicare now negotiates a select amount of drugs for the Part D program. As we know, those negotiated prices for the first 10 go into effect this year. I think, and sorry, this is a long-winded question. A lot of folks in our community have had to go through utilization management, prior auth, step therapy, right? And there have been concerns over that in terms of what some of these downward pressures, changes in who's paying where. It might be too early for you a little bit, but and I know it's a busy time, but what's your take on that? Or are you seeing anything that might indicate any of those fears?
Well, here's the thing. I mean, the drug companies that offer these plans, I mean, they're the portion of my job that gives me my gray hair, because the drug plans are very difficult to deal with. They don't want to, just rubber stamp anybody, especially if they're taking the kind of medications that your community is taking, right? And they'll push back, but they have been a little bit better, in the last few years. And they're all, any of the medications that we talked about just prior to coming on here are certainly going to be affected by quantity limits and, more importantly, prior authorization. So that would reflect like Enbrel, Otezla, Skyrizi, Stelara. Those are all covered by Medicare plans for next year. But absolutely, those will be, they'll be looked at toughly by the, by the drug plans. They're all going to offer that, or they're all going to have those, utilization pieces that are going to make it a little difficult to get. But you might have a situation where you're taking Otezla, and if you pick a drug plan that maybe now it's not covered, but they do cover Skyrizi, you can still get away with it. But again, you just want to make sure that when you're looking at your drug plan for the upcoming year, you try to get the thing as closest as you can to the actual medications that you're taking. That just makes it a lot easier.
Absolutely. Thank you for that. Yeah. And, navigating health insurance, the different health plans, PBMs, right? It's not easy. Right. So appreciate the work you're doing.
And unfortunately, their favorite word is no. So, sometimes they can get a little difficult with, asking for more information from your doctor and things like that. But, one of the things that people have in their arsenal is they can file complaints or grievances with Medicare. Now, what it is I kind of call it like it's like bringing your big brother to a fight, okay? And what I mean by that is the government is actually, looking at their star ratings when they cover these particular plans, and star ratings have an effect on their, on the reimbursements that they get from the government. More on the advantage side than on the drug side necessarily. But the thing is, the more complaints they get about it, making these authorizations difficult for the clients, the worse it looks for them, and that gets affected in their star rating, and eventually that'll hit their bottom line. So, you definitely want to file a grievance if you're having a hard time with these people.
It's I think that's an outlet that a lot of that isn't used as much because maybe it's not known about, or you have to go through the process of submitting that. And so it's something here at the MPF we can't submit any claims for you, but we can certainly provide that kind of education if you're curious of like, how do I go and do this and what does that process look like? So appreciate that, because again, it's an underused resource in my opinion. So this is more of a reminder question, but I think we got a couple of questions in terms of what folks submitted to us, and you probably discussed this now with your clients as well. When you transition to Medicare, you're not allowed to use copay assistance from a third party or a manufacturer, anyone like that. And has the cap brought those conversations to an easier level for you? 2000's, of course, still a lot of money, 2100 this upcoming year, but I think some folks were just curious why that is, and I don't know if you ever dove into that, but would be curious on your thoughts there.
Yeah, so a lot of those programs disappear when you go to Medicare, and I just believe that because Medicare is a government subsidized program, that they almost look at it like it's a double dip, if they're getting the manufacturer's coupons and the government, which doesn't really make a lot of sense to me, because you should really be trying to help the person, and when I do analysis for people where they're coming to me and they're on a group plan, through their employer, and they tell me that they're not paying for, Otezla. And I'm saying, well, that's actually a big piece of the puzzle that we have to factor in to determine whether or not Medicare is a better solution for you. And in many cases, it's basically made people delay their entry into Medicare, and they'll stay on their corporate plan a little bit longer, even if they wanted to retire a little earlier, so it's all part of the analysis. But it's unfortunate that those programs can't piggyback.
Yeah, thank you for that. And we did you just answered one of the questions, and I'm just flagging in terms of I'm still working. I might transition to Medicare, I might not. What should I think about? And I think that's a perfect thing to consider as you're thinking about making that decision. Okay, I think we got. I'll kind of wrap it up with this question, especially for folks either who are just transitioning into Medicare, or even who have been a part of the program and have sort of been through it. With all of these changes that we've seen, right? We're starting to hear a lot more about it. We had the biggest changes to Part D since its creation. There's a lot out in the news, right? Everything's going on right now. What's all that like? Are there a few things you would just say, okay, if you're going to leave this today, here are the things I want you to know?
Well, maybe this sounds a little self-serving, but there was actually an article in the Wall Street Journal yesterday that's talking about what's going on in our world as far as compensation. I've never charged a client, a fee for me to work with them in all the 18 years that I'm doing this. Most of our commissions are being either eliminated or reduced significantly. And the purpose is that the insurance carriers and the government itself think that people can do this on their own. And the one thing I can tell you is that in all of the time that I've been doing this, I probably have had 5 people that came to me in 18 years that really knew what they were doing and they've made the right choices and they were just coming to me for verification, So again, it might sound self-serving, but I do think that there's a value in the services that we provide.
Well, thank you very much. I think not self-serving because, look, I think we really encourage people to reach out, try and talk to as many people as you're making a decision like this, whether someone like yourself and your great company, or just there are resources out there, and trying to navigate this. There are people here to help, and I think that's a great way to close this out. So, Kevin, thank you again. I know your busy time. We really appreciate
You're very welcome.
You joining us. Thanks.
All righty. Take care.
For our viewers, you can continue to learn about the 2025 Medicare changes Kevin highlighted today through a recent podcast episode, Let's Talk, Know Your Medicare Options and What Changes Mean for You, with myself as the moderator, dermatologist Dr. Jeffrey Cohen, and Kim Beer, Senior Vice President of Policy and External Affairs with the National Health Council. Now I'll turn this back over to Bev to give a quick update on additional resources for you.
Thank you, Jason. If you are looking for additional resources to help you with your Medicare journey, visit our Medicare Resource Center to learn more about Medicare Parts A, B, C, and D at psoriasis.org/Medicare-resources. You can view this webinar and other past webinars on our Watch and Listen site at psoriasis.org/watch-and-listen. While there, listen to our podcast series, Psoriasis Uncovered, to hear the latest about managing psoriasis and psoriatic arthritis from a variety of experts in the field of psoriatic disease, including our latest episode about vaccines and psoriatic disease. If you have additional questions about psoriasis, psoriatic arthritis, and treatment options, or if you need help in finding a healthcare provider, contact our Patient Navigation Center by email or phone as indicated on the screen. Thank you, Kevin and Jason, for being here today. On behalf of our viewers, we really appreciate this update about the 2025 and 2026 changes for Medicare. Thank you also to you, our viewer. We hope you found the information helpful and encourage you to provide your feedback on this webinar by taking our short questionnaire via the link under the description on the web page for this webinar. We'd love to hear what you think about the presentation and content. Your feedback will help us identify how we can make our webinars better. We value and appreciate your comments. And finally, this concludes our presentation for the 2025-2026 Medicare Update webinar.